Wilson's disease. Wilson's disease is an autosomal recessive disorder caused by mutations in the ADP7B gene, a membrane-bound, copper-transporting ADPase. Clinical manifestations are caused by copper toxicity and primarily involve the liver and the brain. Because effective treatment is available, it is important to make this diagnosis early. The frequency of Wilson's disease in most populations is about 1 in 30,000 to 40,000, and the frequency of carriers of ADP7B mutations is 1%. Siblings of a diagnosed patient have a 1 in 4 risk of Wilson's disease, whereas children of an affected patient have about a 1 in 200 risk. Pathogenesis. ADP7B protein deficiency impairs biliary copper excretion, resulting in positive copper balance, hepatic copper accumulation, and copper toxicity from oxidant damage. Excess hepatic copper is initially bound to metallothionein, but as the storage capacity is exceeded, liver damage begins as early as 3 years of age. Effective copper incorporation into apocertoloplasmin leads to excess catabolism and low blood levels of ceruloplasmin. Serum copper levels are usually lower than normal because of low blood ceruloplasmin, which normally binds greater than 90% of serum copper. As the disease progresses, non-ceruloplasmin serum copper-free copper levels increase, resulting in copper buildup in other parts of the body, such as the brain, leading to neurologic and psychiatric disease. Clinical presentation. Hepatic Wilson's disease may present as hepatitis, cirrhosis, or as hepatic decompensation, typically in the mid to late teenage years in Western countries, although the age of presentation is quite broad and extends into the 5th decade of life. An episode of hepatitis may occur, with elevated blood transaminase enzymes, with or without jaundice, and then spontaneously regress. Hepatitis often reoccurs, and most of these patients eventually develop cirrhosis. Hepatic decompensation is associated with elevated serum bilirubin, reduced serum albumin and coagulation factors, ascites, peripheral edema, and hepatic encephalopathy. In severe hepatic failure, hemolytic anemia may occur because large amounts of copper derived from hepatocellular necrosis are released into the bloodstream. The association of hemolysis and liver disease makes Wilson's disease a likely diagnosis. Neurologic. The neurologic manifestations of Wilson's disease typically occur in patients in their early 20s, although the age of onset extends into the 6th decade of life. MRI and CT scans reveal damage in the basal ganglia and occasionally in the pons, medulla, thalamus, cerebellum, and subcortical areas. The 3 main movement disorders include dystonia, incoordination, and tremor. Dysarthria and dysphagia are common. In some patients, the clinical picture closely resembles that of Parkinson's disease. Dystonia can involve any part of the body and eventually leads to grotesque positions of the limbs, neck, and trunk. Autonomic disturbances may include orthostatic hypotension and sleeping abnormalities as well as bowel, bladder, and sexual dysfunction. Memory loss, migraine-type headaches, and seizures may occur. Patients have difficulties focusing on tasks, but cognition is not usually grossly impaired. Sensory abnormalities and muscular weakness are not features of the disease. Psychiatric history of behavioral disturbances, with onset in the 5 years before diagnosis, is present in half of patients with neurologic disease. The features are diverse and may include loss of emotional control, temper tantrums, crying bouts, depression, hyperactivity, or loss of sexual inhibition. Other manifestations. Some female patients have repeated spontaneous abortions, and most become amenorrheic prior to diagnosis. Cholelithiasis and nephrolithiasis occur with increased frequency. Some patients have osteoarthritis, particularly of the knees. Microscopic hematuria is common, and increased urinary excretion of phosphates, amino acids, glucose, or urate may occur. However, the full-blown Fanconi syndrome is rare. Sunflower cataracts and Cater-Slasher rings copper deposits in the outer rim of the cornea may be seen. Electrocardiographic and other cardiac abnormalities have been reported but are not common. Diagnosis. Diagnostic tests for Wilson's disease are listed in Table 360-1. Serum ceruloplasmin levels should not be used for definitive diagnosis, because they are normal in up to 10% of affected patients and are reduced in 20% of carriers. Cater-Slasher rings Figure 360-1 can only be diagnosed definitively by an ophthalmologist using a slit lamp. They are present in greater than 99% of patients with neurologic/psychiatric forms of the disease and have been described very rarely in the absence of Wilson's disease. Cater-Slasher rings are present in only 30 to 50% of patients diagnosed in the hepatic or pre-symptomatic state. Thus, the absence of rings does not exclude the diagnosis. Table 360-1 Useful tests for Wilson's disease. Serum ceruloplasmin plus 180350 mg/L 18 to 35 mg/L low in 90%. JF rings plus present in 99% plus if neurologic or psychiatric symptoms present in 30 to 50% in hepatic presentation and pre-symptomatic state. 24H and cubic plus 0.3 to 0.8 mmol 20 to 50 mg greater than 1.6 mmol greater than 100 mg. In symptomatic patients 0.9 to greater than 1.6 mole, 60 to greater than 100 G. In pre-symptomatic patients liver cubic plus 0.3 to 0.8 mol/G, 20 to 50 milligrams per G. Tissue greater than 3.1 mol, greater than 200 milligrams. Obstructive liver disease can cause false positive results. Haplotype analysis. Siblings urine. Copper is an important diagnostic tool, but it must be collected carefully to avoid contamination. Symptomatic patients invariably have urine copper levels greater than 1.6 mol, greater than 100 milligrams per 24H. Heterozygotes have values 1.3 mol, 80 milligrams per 24H. The gold standard for diagnosis remains liver biopsy with quantitative copper assays. Affected patients have values greater than 3.1 mol/grams, greater than 200 milligrams/grams. Dry weight of liver. Copper stains are not reliable. False positive results can occur with long-standing obstructive liver disease, which can elevate hepatic and urine copper and rarely causes Taylor-Fleischer rings. Treatment. Wilson's disease recommended anti-copper treatments are listed in Table 362. Penicillamine was previously the primary anti-copper treatment but now plays a minor role because of its toxicity and because it often worsens existing neurologic disease if used as initial therapy. If penicillamine is given, it should always be accompanied by 25 milligrams/d of pyridoxine. Triatine is a less toxic chelator and is supplanting penicillamine when a chelator is indicated. Table 362 recommended anti-copper drugs for Wilson's disease. Disease status: first choice, second choice, initial hepatic hepatitis or cirrhosis without decompensation, zinc triantine, hepatic decompensation, mild triantine and zinc, penicillamine and zinc, moderate triantine and zinc, hepatic transplantation, severe hepatic transplantation, triantine and zinc, initial neurologic/psychiatric, tetraethyl maldate and zinc. Maintenance: zinc triantine, pre-symptomatic zinc triantine, pediatric zinc triantine, pregnant zinc triantine and zinc acetate is supplied as Velden, manufactured by Gate Pharmaceutical. Recommended adult dose for all the above indications is 50 milligrams of elemental zinc 3 times daily, each dose separated from food and beverages other than water by at least 1 H, and separated from triantine or penicillamine doses by at least 1 H. Triantine is supplied as a trim and penicillamine as cupramine, both manufactured by Merck. Recommended adult dosage for both drugs is 500 milligrams twice daily, each dose at least 1/2 H before or 2 H after meals. For patients with hepatitis or cirrhosis, but without evidence of hepatic decompensation or neurologic/psychiatric symptoms, zinc is the therapy of choice, although some advocate therapy with triantine. Zinc has proven efficacy in Wilson's disease and is essentially non-toxic. It produces a negative copper balance by blocking intestinal absorption of copper, and it induces hepatic metallothionein synthesis, which sequesters additional toxic copper. All pre-symptomatic patients should be treated prophylactically, because the disease is close to 100% penetrant. The first step in evaluating patients presenting with hepatic decompensation is to establish disease severity, which can be estimated using the NAGPR Prognostic Index. Table 363. Patients with scores 7 can usually be managed with medical therapy. Patients with scores greater than 9 should be considered immediately for liver transplantation, and those with scores between 7 and 9 require clinical judgment as to whether to recommend transplantation or medical therapy. A combination of triantine and zinc has been used to treat patients with NAGPR scores as high as 9, but such patients should be watched carefully for indications of hepatic deterioration, which mandate transplantation. Table 362. 3 Prognostic Index of NAGPR score in points. Laboratory measurement: normal value 0.1 to 3 for serum bilirubin, 0.2 to 1.2 milligrams/EL, 5.8, 5.8 to 8.8, 8.8 to 11.7, 11.7 to 17.5, greater than 17.5. Serum aspartame transferase AST 10 to 35 IU/L 100 10150150151 to 0020130, greater than 300. Prolongation of prothrombin time seconds for 4 to 8, 9 to 12, 13 to 20, greater than 28. Hemolysis is present. The serum bilirubin cannot be used as a measure of liver function until the hemolysis subsides. For initial medical therapy of patients with hepatic decompensation, the chelator triantine is preferred plus zinc is recommended. Table 362. Zinc should not, however, be ingested simultaneously with triantine, because it will chelate zinc and form therapeutically ineffective complexes. Administration of the two drugs should be separated by at least 1 hour. For initial neurologic therapy, tetraethyl maldate is emerging as the drug of choice because of its rapid control of free copper, preservation of neurologic function, and low toxicity. Penicillamine and triantine should be avoided because they each have a high risk of worsening the neurologic condition. Until tetraethyl maldate is commercially available, zinc therapy is recommended. Although it is relatively slow-acting, zinc itself does not cause neurologic worsening. Although hepatic transplantation may improve neurologic symptoms, it is so only by removing copper, which can be done more safely and inexpensively with anti-copper drugs. Pregnant patients should be treated with zinc or triantine throughout pregnancy, but without tight copper control, because copper deficiency can be teratogenic. Anti-copper therapy must be lifelong. With treatment, liver function usually recovers after about a year, although residual liver damage is usually present. Neurologic and psychiatric symptoms usually improve after 6 to 24 months of treatment. Monitoring anti-copper therapy when first using triazine or penicillamine, it is necessary to monitor for drug toxicity, particularly bone marrow suppression and proteinuria. Complete blood counts, standard biochemical profiles, and a urinalysis should be performed at weekly intervals for a month, then at twice weekly intervals for 2 to 3 months, then at monthly intervals for 3 or 4 months, and at 4 to 6 month intervals thereafter. The anti-copper effects of triazine and penicillamine can be monitored by following 24H free serum copper. Changes in urine copper are more difficult to interpret because excretion reflects the effect of the drug, as well as body loading with copper. Free serum copper is calculated by subtracting the ceruloplasmin copper from the total serum copper. Each 10 mg/liter mg/L of ceruloplasmin contributes 0.5 mol/liter 3 mg/L of serum copper. The normal free copper value is 1.6 to 2.4 mol/L 10 to 15 mg/L, and it is often as high as 7.9 mol/liter 50 mg/L in untreated Wilson's disease. With treatment, free copper should be 3.9 mol/liter 25 mg/L. Zinc treatment does not require blood or urine monitoring for toxicity. Its only significant side effect is gastric burning or nausea in 10% of patients, usually with the first morning dose. This can be mitigated by taking the first dose an hour after breakfast or taking with zinc with a small amount of protein. Because zinc mainly affects stool copper, 24H urine copper can be used to reflect body loading. The typical value in untreated symptomatic patients is greater than 3.1 mol, greater than 200 mg per 24H. This level should decrease during the first 1 to 2 years of therapy to 2.0 mol, 125 mg per 24H. A normal value 0.3 to 0.8 mol, 20 to 50 mg is rarely reached during the first decades of therapy and should raise concern about overtreatment. Copper deficiency, the first sign of which is anemia and or leukopenia.